Hello, and welcome back to Medical Voices, the podcast where we learn the language of healthcare one real conversation at a time. I'm Tom.
And I'm Nadia. Great to be back.
Before we start, as always, a quick but important note. Everything you hear on Medical Voices is here to help you learn the language of medicine. We are not here to give medical advice, and nothing in this episode should be taken as clinical guidance.
We're language teachers, not your doctors. Though, as you will hear in today's episode, we spend a lot of time in the consulting room.
So, episode 3. And if you have been following along, you already know Mr. Davies. You heard him walk into Dr. Bennett's surgery for the first time in episode 1, headaches and all. You heard him at the pharmacy in episode 2, picking up his prescription and getting his head around amitriptyline. And today, 6 weeks later, he is back.
The medication has made a difference, but something has changed, and that means Dr. Bennett needs to know exactly what Mr. Davies is experiencing, in his own words, and in hers.
Which is what this episode is all about. Describing symptoms. How does a patient communicate what they are feeling? How does a doctor listen, question, and translate that into clinical language? And what happens when a new symptom changes the picture entirely?
10 vocabulary terms, a full follow-up consultation role-play, a language breakdown with some genuinely useful OET content, and a quiz. I will be Dr. Bennett again today.
And I am Mr. Davies. 6 weeks in. A little better. Not quite right. Let's find out why. Right, before we get into the dialogue, let's make sure we have the right words. 10 terms. Nadia will give you the word, the definition, and an example sentence. Pause and repeat whenever you need to.
Terms 8 and 9 are ones you have heard before. We will flag them when we get there, because the context is a little different this time. Term 1. Symptom. A symptom is a sign or sensation that a patient experiences and reports, something they feel and can describe. Symptoms are what the patient tells you. Signs, in clinical language, are what the clinician observes. In everyday use, symptom covers both, but in clinical documentation, the distinction matters. Example. The doctor asked Mr. Davies to describe his symptoms in as much detail as possible.
Term 2. Pain scale. The pain scale is a standardized tool, typically ranging from 0 to 10, used to quantify how intense a patient's pain is. 0 means no pain at all. 10 is the worst pain imaginable. It gives the clinician a consistent, trackable measure across appointments. Example. Dr. Bennett asked where his pain was on the scale of 0 to 10.
Term 3. Onset. Onset refers to the point at which a symptom or condition first appeared or began. A clinician asking about onset wants to know, when did this start? Was it sudden or gradual? Did anything trigger it? Example. Dr. Bennett asked about the onset of the visual disturbances, when they first appeared and how often they were happening.
Terms 4 and 5 go together. Chronic and acute. Listen carefully, because this contrast matters clinically.
Chronic describes a symptom or condition that has persisted over a long period of time. It does not mean severe. It means ongoing. Example. Mr. Davies has been experiencing chronic tension headaches, present for months, not days.
Acute is the opposite. It describes a symptom or condition of sudden, intense onset. Acute does not mean permanent. It means sharp and immediate. Example: the visual disturbances were a new acute symptom, something that had not been there before.
So, chronic means long-lasting. Acute means sudden and intense. The same patient can have a chronic condition and an acute episode at the same time. You will hear both words constantly in clinical English.
Term 6. Diagnosis. A diagnosis is the doctor's identification of a disease or condition based on the patient's symptoms, their medical history, the examination findings, and any test results. Reaching a diagnosis is the goal of the clinical assessment. Example: Dr. Bennett gave a provisional diagnosis of chronic tension-type headache and ordered further tests.
Term 7. Blood panel. A blood panel is a set of laboratory tests performed on a sample of the patient's blood. It can assess general health, check organ function, look for markers of inflammation or infection, and help rule out other causes of a patient's symptoms. Example: Dr. Bennett ordered a blood panel to rule out any underlying conditions that could be contributing to the headaches.
Term 8. Referral. You heard this word in episode 1. Dr. Bennett mentioned it as a possibility if Mr. Davies' headaches did not improve. Today, it becomes a reality. A referral is when a GP decides a patient needs to be seen by a specialist and formally requests that appointment. Example: Dr. Bennett issued a referral to a neurologist for further assessment of the visual disturbances.
Term 9. Prescription. Also from episode 1 and from episode 2, where Mr. Davies collected his amitriptyline, you know this word. But today it appears in a slightly different form. Dr. Bennett is not writing a new prescription, she is extending an existing one. Same medication, same dose, longer course. Example: Dr. Bennett extended the prescription for another 6 weeks, pending the neurology appointment.
And term 10. Provisional diagnosis. A provisional diagnosis is a working diagnosis, the doctor's best assessment of what is happening based on the evidence available so far. Provisional means it may change once test results come back or the specialist weighs in. It is not a weak or uncertain diagnosis. It is an honest and professional one. Example: the provisional diagnosis was chronic tension-type headache, with further investigation to rule out secondary causes.
10 terms. You will hear all of them in the dialogue coming up. If anything felt unfamiliar, especially chronic versus acute, now is the moment to go back.
Ready when you are.
All right. And now, as always, it's time for our role play. Today, I'll be Dr. Bennett.
And I'll be the patient. Mr. Davies, 6 weeks on. Let's go.
Good morning, Mr. Davies. Come in, take a seat. It's good to see you again.
Good morning, Dr. Bennett. Yes, 6 weeks already.
It is. So, this is your follow-up. Let's start with how you have been feeling. The headaches. What is the picture?
Better, I think. Definitely less frequent. I was getting them almost every day before. Now it is maybe 2 or 3 times a week.
That is a meaningful improvement. And the intensity, when you do get a headache, Where would you put it on the pain scale?
Around a 4, maybe a 5 on a bad day. Before, it was a 6 or 7.
So, frequency down, intensity down. The amitriptyline does seem to be helping. What about the ibuprofen? Are you still using it?
Much less. A couple of times since I last saw you. I have been trying to hold off on it, like you said.
Good, that is exactly right. Now, you mentioned when you booked this appointment that there was something new, something you had not had before.
Yes, it is. I'm not quite sure how to describe it. In the last couple of weeks, I have been getting these brief moments where my vision goes a bit strange. At the edge of my vision, like a flickering or a shimmer. It only lasts a few seconds, but it has happened maybe 4 or 5 times now.
I see. Let me ask you a few more questions about that. When did it first start? The onset?
About 2 weeks ago. The first time it happened, I thought it was just tiredness.
And does it happen at any particular time of day, or is it random?
Random, as far as I can tell. No pattern I have noticed.
Is it in both eyes, or just one side?
Just the right side. The right edge of my vision.
And does anything come before it, or after it?
Sometimes a headache follows, within half an hour or so. Not always.
And how long does the visual disturbance itself last?
Seconds. 15, 20 seconds at most. Then it is gone.
Right, thank you. That is very helpful. I want to be straightforward with you, Mr. Davies. The improvement in your headaches is genuinely good news. But this visual symptom is new, and it is something I want to take seriously. Not because I think something is seriously wrong, but because it is a new symptom, and it is not something I want to simply observe and wait on.
Should I be worried?
I would not say worried, I would say informed. What I am going to do is order a blood panel. That will let us check your general health markers and rule out anything that could be contributing to what you are experiencing. And I'm also going to refer you to a neurologist.
A neurologist? That does sound significant.
It is a specialist who looks at the nervous system, the brain, the nerves, and this is what referrals are for. Not because I am concerned about something serious, but because a neurologist is the right person to assess a visual symptom like this, and I would rather be thorough than not. It does not mean anything sinister. It means we are doing this properly.
How long will the referral take?
That can vary. I will mark it as routine for now. If the visual disturbances become more frequent, or last longer, or you experience anything else new, call us straight away, and we can escalate it. In the meantime, I'm going to extend your prescription. Another 6 weeks of amitriptyline at the same dose, while we wait for the neurology appointment. The headache improvement suggests it is working, so there is no reason to stop now.
And the blood panel, when does that happen?
The receptionist will give you a form on the way out. You can take it to the phlebotomy clinic at the hospital. No appointment needed. Any questions?
I do not think so. I mean, it is a lot to take in, but I understand.
That is perfectly normal. Mr. Davies, you came back when you said you would. You have been managing the medication sensibly, and you flagged a new symptom clearly and calmly. That makes this consultation much easier than it might have been. Well done. Take care, and we will see you once the neurology appointment comes through.
Thank you, Dr. Bennett. We are going to repeat 3 key exchanges from that dialogue a little more slowly so you can focus on the phrasing and the vocabulary.
Pay attention to how symptoms are described and how the doctor responds to a new and unexpected finding. You mentioned when you booked this appointment that there was something new, something you had not had before.
In the last couple of weeks, I've been getting these brief moments where my vision goes a bit strange. At the edge of my vision, like a flickering or a shimmer. It only lasts a few seconds, but it has happened maybe 4 or 5 times now.
When did it first start? The onset.
About 2 weeks ago. The first time it happened, I thought it was just tiredness.
Is it in both eyes or just one side?
Just the right side, the right edge of my vision.
And does anything come before it or after it?
Sometimes a headache follows within half an hour or so, not always.
And how long does the visual disturbance itself last?
Seconds. 15, 20 seconds at most. Then it is gone.
What I am going to do is order a blood panel, and I am also going to refer you to a neurologist.
A neurologist? That does sound significant.
It is a specialist who looks at the nervous system. This is what referrals are for. Not because I am concerned about something serious, but because a neurologist is the right person to assess a visual symptom like this. It means we are doing this properly. I am going to extend your prescription. Another 6 weeks of amitriptyline at the same dose, while we wait for the neurology appointment. Let's break that down. There are a few expressions and patterns in that dialogue worth looking at closely.
6 things. A mix of vocabulary, clinical frameworks, and some language that is particularly relevant if you are preparing for OET.
Let's start with how symptoms are described. Because in the role play, I was asking Tom a very specific sequence of questions, and that sequence was not random.
Clinicians, especially in the UK, use a framework called Socrates to structure symptom assessment. It stands for Sight. Where is it? Onset. When did it start and how? Character. What does it feel like? Radiation. Does it spread anywhere? Associations. Are there other symptoms with it? Time. How long does it last, and does it follow a pattern? Exacerbating and relieving factors. What makes it worse or better? And severity. How bad is it on the pain scale?
In the role play, you heard almost every one of those questions come up naturally in the conversation. That is not a coincidence. If you are preparing for OET Speaking, knowing Socrates gives you a structure for eliciting symptoms from a patient and for describing your own clinical reasoning in a written task.
The patient side of Socrates is just as important. In the role play, I described location, the right edge of my vision. Onset, 2 weeks ago. Character, a flickering or shimmer. Duration, seconds. Association, sometimes followed by a headache. That is a clinically rich description given entirely in everyday language, and that is what you want to be able to produce.
Point 2. Chronic versus acute. We presented these as a contrast pair in the vocabulary segment, and it is worth spending a moment on why this distinction matters clinically, not just linguistically.
The headaches in this episode are chronic. They have been present for months, building since episode 1. The visual disturbances are acute. They appeared suddenly 2 weeks ago with no prior history. Same patient. Two very different clinical categories.
That distinction changes the management plan entirely. For the chronic headaches, the approach is ongoing: medication, lifestyle, monitoring. For the acute new symptom, the approach is investigative. Something new has appeared and needs to be understood. A clinician who can articulate that difference clearly in a patient note, a referral letter, or an OET written task is demonstrating exactly the kind of precision that clinical English requires.
Point 3. The pain scale. You heard it in episode 1, and it is back in episode 3, but this time it is doing something different.
In episode 1, the pain scale established a baseline: 6 to 7 out of 10, almost every day. In this episode, the same scale shows change: 4 to 5 out of 10, 2 to 3 times a week. That is the clinical value of a standardized tool. It makes progress, or deterioration, visible and comparable across appointments. You cannot track what you have not measured.
The language of that exchange is worth noting too. I said around a 4, maybe a 5 on a bad day. That qualifier, maybe a 5 on a bad day, tells Dr. Bennett something about variability. It is not just a number. It is a picture of how the symptom behaves. A good patient, or a good OET candidate performing the patient role, gives the clinician that kind of nuance.
Point 4. Blood panel. This word is important because patients often misunderstand what it means, and clinicians need to be able to explain it clearly.
A blood panel is an investigation. It is a tool the doctor uses to gather more information. It is not a diagnosis. Ordering a blood panel does not mean the doctor knows what is wrong. It means the doctor wants to check certain markers before deciding. Explaining that distinction to a patient in plain, reassuring English is a core clinical communication skill.
In the role play, I did not say, "I am ordering a blood panel because I think something is wrong." I said, "A blood panel will let us check your general health markers and rule out anything that could be contributing." That framing is deliberate. Rule out is one of the most useful phrases in clinical English. It signals precaution, not alarm.
Point 5. Referral. In episode 1, Dr. Bennett said, "If things don't improve, I may consider a referral to a neurologist." In episode 3, she actually issues one. Same word, completely different weight.
The language of issuing a referral has 2 jobs. The first is clinical. It communicates what is happening and why. The second is relational. It has to reassure the patient that this is not alarming. In the role play, Tom's reaction was immediate. That sounds significant. That is a completely natural patient response. And the clinician's job is to hold the space for that reaction without dismissing it and redirect it.
The phrase I used was, "It does not mean anything sinister. It means we are doing this properly." That is the language of professional reassurance. It acknowledges the patient's concern, reframes the referral as thoroughness rather than alarm, and gives the patient a way to hold the situation calmly. For OET candidates, this kind of relational language is assessed directly in the speaking subtest.
And point 6, provisional diagnosis. This is the last term in our vocabulary list, and one that learners sometimes underestimate.
A provisional diagnosis is not a weak diagnosis. It is an honest one. It means, based on everything I know right now, this is my best clinical assessment, and I am keeping it open to revision as more information comes in.
In clinical writing, referral letters, discharge summaries, handover notes, you will often see phrases like, "The provisional diagnosis is chronic tension-type headache," or, "We are working on a provisional diagnosis of migraine with visual aura, pending neurology review." These phrases do not signal uncertainty about the clinician's competence. They signal clinical accuracy.
The companion phrases to learn alongside provisional diagnosis are most likely, as in, this is most likely tension type. We want to rule out, as in, we want to rule out any secondary cause. Pending further investigation, as in, provisional pending the results of the blood panel. These are the phrases that turn a good clinical note into a great one.
Which brings us to the quiz. And now, quiz time. 3 questions. Tom, you ready?
Always.
Question 1. What is the difference between an acute symptom and a chronic symptom? 5 seconds. Think before you listen.
A chronic symptom is one that has persisted over a long period of time, ongoing, lasting. An acute symptom is one of sudden, intense onset, new and sharp. The same patient can have both at the same time. In this episode, Mr. Davies had chronic tension headaches, months old, and an acute new symptom, the visual disturbances which appeared suddenly 2 weeks before the consultation.
Question 2. What is a blood panel and why might a doctor order one? 5 seconds.
A blood panel is a set of laboratory tests performed on a blood sample. A doctor orders one to assess a patient's general health, check organ function, look for markers of inflammation or infection, or rule out underlying conditions that might be contributing to the patient's symptoms. It is an investigation, a way of gathering more information, not a diagnosis in itself.
Question 3. When a GP issues a referral, what are they doing and what should the patient know? 5 seconds.
When a GP issues a referral, they are formally requesting that a patient be seen by a specialist, in this case, a neurologist. The patient should know what kind of specialist they are being referred to and why, roughly how long the wait might be, what the referral is intended to investigate, and what to do if their symptoms change in the meantime. A referral is a precautionary and thorough step, not a signal that something is seriously wrong.
3 questions, 3 clear answers. Well done if you got those. And if you did not, the vocabulary table in your PDF transcript is there for exactly that reason.
That is episode 3. Mr. Davies has a blood panel to do and a neurology appointment on the way, which means next time we're at the hospital. Episode 4 is all about the hospital intake process. What happens when you arrive as a patient? Who do you speak to? What does the admissions team need from you? And how do you give it to them? New setting, new vocabulary, same Mr. Davies.
It is a big one. Do not miss it.
See you next week.
See you next week.